So good afternoon, ladies and gentlemen. In fact, in most of the meetings, we have always been discussing one Phakic IOL. And there are people who, for different reasons, want to use different Phakic IOLs. And sometimes they're at a loss to understand what is the advantage and disadvantage of a particular Phakic IOL. We fortunately have had the experience with all the Phakic IOLs in the market, and probably with this I may be in a position to give you a little idea about all the Phakic IOLs present in the market and a little bit of idea of some tough realities we have to face with Phakic IOLs. So this is going to be a little different from what we are used to seeing. So just to get the start, I'll take you to something interesting.
Hello, my dear masters. I am your friendly ICL. You can use me to correct 18 diopters of myopia and 6 diopters of astigmatism. I am quite like a child, my dear masters. If you treat me with care, I get playful in your hands. I then sometimes try to open on the sides. But then, you, my master, correct me with a gentle twist of the injector. Sometimes I open upside down. But I know my experienced masters can handle me well. For my new masters, let me tell you, please don't try to turn me around within the eye. I could damage the endothelium. Rather, just pull me out and insert me again. It is all so easy. If you, my masters, look good in right-fitting clothes, I also look good in right-fitting eyes. But some of my masters don't size the eye properly, and I am pushed into a cramped, smaller-fitting eye. Because of this mismatched sizing, I can't help cause shallowing of the chamber and risk of glaucoma. Some people have been blaming me of causing cataract. It was only when the kind Dr. Shimizu presented me with a central hole, I could now proudly announce to the world that I cause no further cataract. My masters, Dr. Jose Alfonso and Dr. Sanjay Chaudhary from India, have presented their 3-year series without a single cataract. One of my masters in his early learning period accidentally placed me upside down. I maintained my cool and waited for someone to come and rescue me. Because of my shape, I had to maintain contact with the crystalline lens, while my legs pushed the iris against the cornea, causing peripheral anterior synechia and secondary glaucoma. Four years later, I was discovered by Dr. Chaudhary, who was kind enough to let me out. He released some synechia too and replaced me with my brother, the Centraflow. But let me tell you this, in my 4 years of contact with the lens, I never induced any cataract. And therefore, my dear masters, I am a very bio-friendly lens. Treat me with respect and care, and I will never let you down.
I hope you like that little bit of animation. Don't miss the earring on his ear, one ear. So that suggests, is he a male or a female? Male. Okay. And this film I made about a couple of years back, so that's why it says 3 years of experience. Now this film is almost about 5 years back. Some very interesting things in this which I've tried to tell you. The last video showed that somebody had put a lens upside down. And that lens was in touch with the crystalline lens for 4 years. And the haptics were pushing up the iris against the cornea, causing total annular synechia. Somehow, the doctor never realized what the problem was. He just thought secondary glaucoma because of ICL. And they kept treating him with glaucoma medications. When we took a slit lamp profile, we thought something very different. The whole slit is showing a curve upward rather than a curve downwards. So we took it out and replaced it. But what was noticeable, that was even after 4 years of contact with the crystalline lens, there was no cataract. That was what was unbelievable. And the person had a fairly good amount of vision. Of course, there was a little damage because of the induced glaucoma. So, I think we have seen a lot of surgeries for ICL. Do you want to see a surgery of ICL? Should we go to the discussion? Huh? A small video? Okay, so I'll show you a small video on ICL and then a little small video on the other techniques. So, नहीं अब sound नहीं है ना वो एक ही में थी. So, I do ICLs in two ways: viscoinsertion and hydroinsertion. They both have their advantages and disadvantages, which I can discuss in the discussion part. Here, I'm doing a viscoinsertion, and this is what I advise all people who are starting with ICLs. They should do that for the first 50 cases. Then they may choose whatever. Both are good. But to start with, this is a much safer system. You don't need too much of tools, a Mendes ring, an axis marker. You mark the position. These are the axis marks. Two side ports with pupil dilator and anesthetic, intracameral, visco, main port. Main port is 3.25 millimeters. Of course, you can push it to 3 millimeters, but the surgery has to be not wound assisted. The tip of the injector should be just crossing the inner lip of the corneal incision, so that the ICL does not touch the edge and veer to one side. So, pulled into the cartridge, into the nozzle. Position in the injector. And inject it slowly. This was a fast injection system, but normally I say inject 2/3. See how it is opening. If you think it is opening fine, push the rest of the way. But if it is not opening fine, when it is 2/3 in, you can always pull it out and reload and re-inject again. So always push in 2/3, let the ICL tip open up, see the position, and then tuck in the haptics. This is gather, 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 and tuck. So gather, 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 tuck. Tucking is not a challenge. In fact, the whole procedure is not a challenge. You can tuck the distal ones first. You can tuck the proximal haptics first. That's your choice of fine tuning on the right axis. And then we go for visco removal. one thing is very important in this step, that you should not go under the ICL to remove the visco. We talked about it earlier. Dr. Sarika will talk about it in detail. So at this time, this is an old video. You can see I'm going under the ICL. Can you see that? Again, I kept this video to show you this maneuver should not be done. Try to move it away from the, get the visco out from everything over the ICL. A direct stream hitting the anterior capsule can induce cataract changes, anterior subcapsular. Dr. Sarika will show you some slides on that. So that is a very important step. You can insert an ICL under visco, you can insert the ICL under hydro. That's not too relevant, it just saves on a little time. Hydrate all the 4 ports, all the three ports, both sides, so that you have a good seal. I patch up the eye for about half an hour. We do both eyes together. After half an hour, when the chamber has stabilized, we remove the patch, have a look at the patient, send the patient home. So that is a simple basic about this procedure. A little about ICL. Okay, so this is the ICL. Notice the size on the finger. Notice the curve, which is what we call the vault. Notice the position in the eye, behind the iris, in front of the crystalline lens. This is the range of ICL available, 0.5 to 18 in steps of half diopter, and an 18 power ICL would correct approximately 17 or 17.5 diopter of spectacle correction. Plus 1 to plus 10 would correct 0.75 to approximately 7 diopters of spectacle correction. So it means that if the ICL is coming with a power of 10, don't be led into believing that now you can correct 10 diopters. Cylinder 1 to 6 will correct about 5.5, half a diopter less. So ICL power can be compared to specs power in a kind of an approximation. So it is usually 1 diopter more than the spectacle power in the normal ranges. And so if it is 9, it will be 10. However, when you reach 18, it is half a diopter less. So these are about the powers. Why it is important to know about the correlation of the power, spectacle power to the ICL power is because when you say you are correcting a person with -9 spectacle power and you give them the box which says -10, they come running in a rage. सर आपने हमारी आंख में गलत ICL डाल दिया, हमारे चश्मे का नंबर 9 था, आपने एक 10 नंबर का डाल दिया. And then you need to explain कि this is how the optics work, because when you have a number like this here, you need less power to focus on the retina. You get closer, you need more power. You get closer, you need more power. You get closer, you need more power to get the focus onto the same retina. So the closer the things get to the retina, you need a higher powered lens to bring the focus to that point, right? So, this is our simplified refractive nomogram. 1 to 8, we are doing LASIK or Contura. 8 to 17.5, we are doing ICL, and the maximum power of ICL is 18, which corrects 17.5. Beyond that, the ICLs are not manufactured. So, if you have interest in other company lenses, you can use them till a range of 25. There are other good lenses in the market too, like the IPCL and the Biotech. In plus numbers, in low numbers 1 to 4, we are doing Contura, and 4 to 7, we do ICLs or refractive lens exchange. These are generalized things, but you can always have, depending upon the status of the cornea, maybe the cornea is not good at all and you are doing ICLs in a power of 2, 1.5. Yes, in torics, even for half a cylinder, we are using a toric ICL. Why leave half adapter to chance? Patient at that age, and more than the patient, their parents are very fussy. So, more or less, very few now what we are doing is spherical. Most of our ICLs are toric. So, this is a lens design with a vault, and this, if the ICL is totally flat, still the vault would be about 80 microns. So, it is not that it will follow the contour of the lens, that is the vault. And that is the vault with the central hole. I will come to that later. So, this is the ICL design, and there is a central hole, which is 360 microns. And this is the latest model which they have, which is called V4C. And this ensures a movement of the aqueous from the posterior chamber to the anterior chamber. There is no aqueous stasis under the ICL, and that is why now the incidence of cataract is almost 0. So, when there is a fear of cataract after ICL, you can be almost assured that virtually we are not facing cataracts at all for the last 9 years. But of course, there would be some reports somewhere or other, but more or less there is no cataract. So, this is the ICL seated in the eye, and this is the movement of the aqueous through the ICL from the posterior chamber to the anterior chamber, and that keeps things safe in this area. So, you have two types when they will bring the lens to you, and EVO, they change the name of ICL to EVO. There is one EVO and there is one EVO Plus. EVO is the regular ICL we are used to. EVO Plus is an ICL with a larger optic. So, less number, and you can afford to have a larger optic. It is more useful for people who have a larger pupil, a larger mesopic pupil. A larger optic would work there, but this lens with a larger optic comes only till a power of -14. Because beyond that, to increase the power and not increase the thickness, you have to reduce the optic size. So, it is EVO beyond 14 till 18, and less than 14 is EVO Plus. This is the ICL seated in the eye, the dilated pupil and undilated pupil, and you can order your ICLs from this company, which is this address with you. You log on to this address, and you will get an email and a password, and then you can start your system, do your calculations and order your ICL. So that was something very basic which I told you. ICL workup, would you want me to go to ICL workup? Okay, so we'll talk a little bit about ICL workup. Okay, so the three main things that you need to do in an ICL workup: the refraction, the white to white for ICL sizing, and the anterior chamber depth. These are the most important three parameters. That's it. But then there are a few secondary parameters which are equally important. History would be important to know the refractive stability. Is the number stable or not? Pregnancy or weaning period, hormonal changes can affect the refraction. Then others which we do as a routine is a retina check, because you don't want to miss a hole or a lattice which could later cause a problem, because if a person develops a retina detachment after an ICL surgery, even after 1 year, 2 years, 3 years, that person is going to say कि पहले तो मेरा बच्चा बिल्कुल नॉर्मल था, जो भी हुआ ऑपरेशन के बाद हुआ है. So it's important to check the whole thing. Even if it happens somewhere in life, you say, that time I checked the retina, this is the report, your retina was normal, whatever has happened afterwards. And if there was a problem there at that time, you correct it. And you tell them that I am correcting it now, because if something happens to you afterwards, you would blame me that it has happened because of ICL. Most of the patients understand that. Dry eye status, keratometry, axial length. Why axial length? Because you want to know whether a change in number over a period of time is because of actual progression or because of any other factor. Endothelial cell count is relative, angle measurements are important. Now we talk about the first point, refraction. It has to be a dilated refraction. That is, then you do a PMT. And the final ICL power will come as a transposed power, which means if you have a number of -12, -6 at 90, if you transpose this, -6 at 90 will become +6 at 180, and you add the cylinder to the sphere, it will become 18. So the power would be 18 plus 6 at 180. So when your ICL is coming at 18, you are not actually getting -18. In this situation, you are actually getting -12 with +6 cylinder. So if you have a power like this, -16 -6 at 90, if you transpose it, look down here, you would get 22 plus 6 at 180. But 22 is not available. So what you would do is you would correct 18 plus 6 at 180. Right? Till this point, I'm going slow because these are some very basic things, but very important things when you make a start. You have other lenses in the market. ICL has limitations because it is an FDA approved lens. They can manufacture what is an FDA guideline. So probably they cannot increase their range unless they put in all those studies and get approvals. However, there are others which are not FDA approved, can extend their ranges. So you'll get people who are manufacturing other phakic IOLs who can extend their ranges. So with these extended ranges, you can correct much higher numbers. So sorry. Okay. Now, the sizing is very important. In all meetings, it is all about sizing. ICL primarily comes in these four sizes: 12.1, 12.6, 13.2 and 13.7, where 12.6 and 13.2 are the main used sizes. 12.1 and 13.7 are the outliers. For every sizing, you keep hearing of white to white, white to white, white to white. And actually, nobody is very clear what is white to white. So, this is white to white from this point to this point, right? But if you look at this picture shows that there are three white to whites. So you have this white to white where the edge of the sclera finishes, and there's this little hazy limbus area to the edge of the sclera here. Then you have this clear cornea to clear cornea, which is at the bottom. And there's quite a difference. It's almost a millimeter at times or even more. And then there is a fair compromise, a mid to mid. So, clear cornea to clear cornea is almost never used. Either mid to mid, and you titrate your results and come to know how you're getting results, or true white to white. All these electronic gadgets, they're giving you true white to white. And that is why sometimes you have readings in them a little more than what you calculate with a vernier caliper. So these are the instruments that you use. You use a digital caliper, which is the first one. A simple tool, a not so expensive tool, gives you consistent and good results. And then you can have higher systems like optical biometer. You can have a pentacam. This is out. Please, this is out. A vernier caliper. And I'm sure still a lot of people who want to start still use a vernier caliper. But that is easily available. You have this, every doctor has this instrument at home in their practices. And they automatically tend to measure it with a vernier caliper. Please, this is out. Vernier caliper may be costing you 300 rupees. A digital caliper may be costing you 3,000 rupees, probably 2,000, something like that. But if you are into ICLs, please invest in a digital caliper. Okay, so this is something. When you order an ICL and you have more machines or something, you have to know this kind of a comparison. That if your digital caliper is showing 11.7, the pentacam is about 0.2 more. The optical biometer is about 0.5 more, 0.5 or 0.6. So which one would you choose? Huh? Actually follow the digital caliper, but all the three are pointing to the same white to white. All the three are pointing to the same white to white. As a routine, pentacam shows about 0.2 more than a digital caliper. And optical as a routine shows about 0.5 more than a digital caliper. So, if you are getting these three values, then you are bang on. Right? This is very important to understand, because you would be confused from how do I start. Okay, so this is about the anatomy. When you listen to a lot of presentations, some higher type of presentations, they talk about white to white, angle to angle, sulcus to sulcus. So this is white to white from here to here. This is the angle, So angle to angle. This is the sulcus, so sulcus to sulcus. The ICL sits in the sulcus, and in all probability, we are not measuring the sulcus. The sulcus can only be measured with a UBM, which even I don't have. A easier way is angle to angle, but then you again need a good OCT, ASOCT to do those angle to angles, and where they would capture the whole length in one view. So you need higher end OCTs. Okay. A little point of confusion is when you're doing 12.6 and 13.2, if you notice from the sizes here, an 11.6 wide to wide says you put a size of 12.6. And 11.7 wide to wide, just 0.1 millimeter change says you put a size of 13.2 from here. These values. 11.6, you do 12.6. 11.65, you change to 13.2. So half a millimeter change, or sorry, 0.1 or less than 0.1 change, and the size changes by half a millimeter, which is a massive change. So this is where you have to play with your other indicators, how to get to the right sizes. So this could depend upon, this is a borderline situation. This is your angle. A 45-degree angle is a good open angle. A 20-degree angle is a narrow angle. So this is showing an open angle. Do a gonioscopy or an ASOCT to see what kind of an angle you have. If you have a wide angle, you could try something a size higher. If you have a narrow angle, try a size lower. Look at the ACD. If you have a higher ACD, you could try a size higher. If you have a lower ACD, you could try a size lower. This is the minimum anterior chamber depth that should happen, 2.8 in myopes and 3 in hyperopes. It is not 2.8 in hyperopes because you would have a very different ratio where the lens is also getting larger, your oral spaces are less, the eye is shorter in size, and you could land into a problem. So 3 is the minimum cutoff for this, okay? Now, I come to the topic of the day. I'm going to compare. I use ICL as my primary lens, but I've also used all the other lenses available in the market to understand those lenses, to see how they compare to the ICL and how they compare to each other. It's good to have a little knowledge of everything so that at times you may need to choose a lens which may suit you better for a particular situation. So I'm talking about the biotech lens. So a little about the biotech lens. This is called the AIOC2022-Phakic IOL. It looks more or less similar. It has a central hole, and it comes as a spherical and it comes as a toric. And if it comes as a toric, there are these axis marks here. Like any other phakic IOL, they have their axis marks, and you have to place them on their axis marks. They have, ICL has a hole in the right haptic and the left trailing, right leading haptic. Biotech is the reverse. In fact, if you notice, ICL is the only plate haptic design which has a hole in the right leading, left trailing. All plate haptics, IOLs, ICLs, they have the hole in the left leading, right trailing. Almost all, it's almost a rule. So the moment you get a new lens, look at where the holes are. Put that to memory. But I've seen so many lenses, it's only ICL which is right, all others are left. About this biotech lens, it has to be placed in axis, and all these lenses have a condition that they should not be, because you're measuring white to white in the horizontal, the lens should also be lying horizontal or should not be displaced too much from the horizontal. Right? So what biotech has done, it has 6 models. One model where there is an axis here, 0, 180. Then it moves in steps of 30, 30, 60, 90, 120, 150. So they have 6 models. And that means if the steps are of 30 each, it is 15 degrees on either side. So you have to move the lens only 15 degrees either side. But when you place this lens, the axis has to be placed on the axis which you have marked on the cornea. It's a very simple calculation. The axis of the lens just comes on the axis of the cornea. Unlike ICL, where you say that the lens has come at an axis of 10 and you have to put it at an axis of 20, so you have to rotate it by 10 degrees. Here it is straight. The axis is here, the corneal axis is here. You just go inside the 2 and that's the end of it. So that's one simpler point in this. This is a comparison. I'll come to it when the comparison comes. So I'll just show you the video of biotech insertion. Essentially what you will notice is that insertions of all the lenses are more or less similar. Now I'm showing you an insertion with the help of a digital caliper. First I showed you one which was the manual one. This is the packing of the biotech lens. This is how it looks. Similar, central hole in the left leading, right trailing. These are the axis marks, 0, 180. At axis at 90. Now, in this injector, you place this lens upside down. You place this lens upside down. This is a Medicell injector. It's a beautiful injector. You place this lens upside down, and then once you click this wings in position, with this you push the lens forward to this point, and then this lens would go through 2.8. So now my axis is 40 degrees. This is the lens opening out. And you see these marks. These are the axis marks and they have to be aligned at 40 degrees. That's it. So I can use two manipulators, bring these marks into position. The tucking is similar. But these lenses are thicker than the star lenses. So they are a little harder to manipulate, harder to flex. And sometimes in the older injectors, one really had to use a lot of effort to push the lens into the eye. the new injectors are a savior, but the old injectors which are still in use, you will have to really struggle and put all your strength behind to get the lens into the eye. This is just the design of the injector. So you load it upside down, click it, and then you turn it around like this so that the bevel is down. It's just how they place the bevel. Had they placed the bevel the other way around, it would have gone, we would have to place the lens like this. It's just a matter of design, nothing special. Ultimately, the lens has to open up like this into the eye and the bevel down. That's it. Either way, they got this design made like this. The advantage of this is when you place it upside down, it falls very well into the grooves. And it holds like this into the grooves. So when you flex it, it is flexing along the curve of the injector. So that's a good design. I like that design. So when you just, it flexes, when you, the injector is like this, the lens is also like this. Otherwise the lens would have been like that. So it goes with the contour of the injector. It stands into the grooves, clicks very well. You're not worried that the lens would be bulging up and then it might tear or something. So it's a good design. It was a pretty, I like the new design. Sorry. Okay, then we have another popular model, which is the IPCL, which is by the Care Group. So this is their older version, this is their newer version. Again, they have a central hole. I asked all these people, I thought the central hole was a trademark, registered trademark of the Star people, but probably a trademark is meant for 12 years. And after 12 years, anybody can use it. That could be the reason. So anyway, everybody now has a central hole. And these two holes, they were originally there with IPCL. When they didn't have a central hole, so they decided to retain these holes also. The problem with an IPCL before was because they had these peripheral holes and not a central hole. And the iris used to cover these holes. So you could have secondary glaucoma. The aqueous movement was not free. But ever since the central holes have come in, you don't have stasis, you don't have IOP rise because of these. I'll keep the rest of the things to the discussion when I compare all the four in a different format. Now, this is a PRL we have heard of. We heard of that about 15 years back. Then the PRL went out of the market. It was purchased by Medinium. And now it is the Medinium Phakic lens. MPL, Medinium Phakic lens. Now, just a little bit about the Medinium Phakic lens, previously called the PRL. It comes in two sizes, MPL 100, MPL 101, two designs, two sizes, and the 10.8 matches the 12.8 of ICL, 11.3 matches 13.2 of ICL, size-wise. Why is this? Because they only come as spherical lenses. They don't come as toric, and they are shorter in length, and they are not seated in the sulcus. They are floating. That is why they are moving in the eye, and that is why they can only correct the spherical powers. So they are floating lenses. They have a central hole too. But because they are short and floating, I asked them that in any case the aqueous is only moving around it because it is not covering the whole edge. So they say the central hole is so that when the aqueous goes from the center upwards, it works like a parachute. If you notice in the older parachutes, the way to keep the parachute central was the parachute has a central hole like this, and when the air goes from the central hole up, it keeps the parachute in position rather than let it stray this side, that side. So they call this also the parachute technology, centering technology. It comes till a range of 28. I've used the 28 model in a couple of cases. So 28 plus another 8 by LASIK can correct how much? 36. So now you can even correct 36 in a bioptic without losing on the accommodation of a young person. Okay, so this is a very interesting lens. Though now, since all the other companies have come up with their higher powers, and most of these higher powers do have a cylinder, so probably this lens has a very limited application. So this is putting it into the injector. So this is where you were asking the question that what if the lens is like this? So you have to ensure that it goes into the groove well, push it down through the center, and then close the flaps of the cartridge. And it jumps out. It always jumps out. A feature not really liked. And then you can just remove the visco, that's it. And then tuck it into under the iris. Tucking is very simple because there is nothing like a axis. It's a little harder lens, so you can just hold the center and tuck both the sides of the haptic together. It's like a plate. You can tuck the whole plate together, one side, the other side. It's very simple to use, exceedingly simple to use. And now comes a lens which is beginning to come up. The lens by the Appaswamy people. This is the 5th Phakic lens in the Indian market. They have brought a whole range. It is called RIL, refractive implantable lens. And it has the range of correction is full up to 26, and it comes with these 4 holes at the periphery. This is something which I really don't like because this is where the iris is going to cover these holes and cause problems. But that's my personal impression. Okay, so we come to the comparison. The thing that most of us would like to know, how do they compare to each other? So I've made you a comparison slide, so which will give us a comparison at a glance. Okay, so let's look at this comparison. Incision size could be 3.8 for a star ICL, 2.8, 2.8, 2.2, but incision size is really not that important. You can put an ICL through 3 millimeters. I put an ICL through 2.8 millimeters. But yes, it's the good control is important. So in fact, all these lenses I put through 3.2. I'm much more comfortable. The range, ICL range stops at 18. The others go up to, the biotech goes up to 25. The IPCL goes up to 30. So if you are doing a bioptics, 30 plus 8, you can do 38. You can keep that in mind in case you have a situation. Rather than say, okay, I can correct 35 and I'll leave 3. Why leave 3? Correct 38. You have something in mind, na? The patient will be jumping with joy. 38 का चश्मे का नंबर उतार दिया, ये तो डॉक्टर साहब बिल्कुल ही मिरेकल है. And others will start wondering कि यार ये 38 कैसे उतार दिया? Okay, same with the MPL, it comes at 28. Cylindrical correction, ICL has up till 6. More or less same. IPCL has a greater flexibility of range. They come with a cylinder of 10. And both the IPCL and the biotech, because they are made in India, they can customize it to your requirement. So I've had cases where I had a cylinder of 10. I've had cases where I had a cylinder of 12. And I got them customized and the results were really good. I had a high keratoconus, very high cylinder. So we were thinking of first reducing the cylinder with those rings. And then we thought, why do that? Let's straight away use a high cylinder lens. Unnecessary use an Intax first and then do this. Let's try this, and it worked very well. Then the size. Star has these 4 sizes. So if I need to have a size where the size would be less than 12, the option is not with ICL, but yes, Biotech makes it till 11.5 steps. So in very small white to whites, I then tend to use a Biotech. And look at IPCL. They make lenses in steps of 0.25, not even 0.5. So even those confusing areas where 0.1 millimeter will make you jump by half a millimeter more of the lens, you can choose a mid size. They have that advantage. Press bipic solution. At the moment, only IPCL has a press bipic lens. That means you can correct your distance power and an add of about 1.5 to 2. So the patient could be very happy and still have some accommodation left. You not remove the natural lens, and the patient is not happy, you can pull it out. ICL is launching its press bipic lens in the ECRS, I believe, in September. And they would be, this already got their FDA approvals and everything, and they would be a big game changer in the system. Optic size is more or less the same in all. Dialing range of correction, how much the lens has to be dialed on either side. And ICL has to be dialed up till 22 degrees. Phakic lens, I told you 30 degree steps, so 15 degrees on either side. IPCL is doing what is called a smart phakic lens. That means you don't have to worry about dialing. Everything is 0-180. It has a built-in access into the lens. So if you are troubled by this fact कि यार मैंने 10 डिग्री इधर घुमा दिया या 5 डिग्री उधर घुमा दिया तो कुछ गड़बड़ तो नहीं हो जाएगी. You don't have to put your mind to it. They do all the calculations. You just put it 0-180. Lens thickness, I said, the best thickness I feel is of the star. The best thickness, the best consistency, the best opening rate, control rate is star definitely. Biotech is a very thick lens. They feel that is an advantage because it makes the lens a little stiffer and it holds on to the vault better. It's not collapsible. IPCL is thinner than ICL. It's very collapsible. But they're all working. And the biggest thing, the brand value. ICL takes the cake. Yeah. In all of these procedures, nobody is taking that into account. They used to only take it for cataract. But in phakic IOLs, they don't take it into account, and now even the cataract people don't take it into account. So the cataract people also now say that 2.2, 2.4 incision is not going to induce astigmatism or will induce 0.1 diopter of astigmatism. So most of the people are eliminating the SIA. The phakic IOL people never included the SIA, and it still worked. Even at 3 point it worked. It's still working very well. So now the discussion. Okay, what is my choice? When people still ask me, what is your choice? I think the doctor is guided by what his patient wants. And when the patient goes to the net and reads, there in his psychology is something, an imported lens, Indian lens, a branded lens versus a non-branded lens. And the cost becomes pretty secondary. Why secondary? I'll tell you. I'll give you an example. There was this family. Daughter, mother, and mother's father. 3 generations. The daughter had a power of -5, 6. And I gave them an offer, you can do SBK or you can do a Contura. Contura is 1 lakh, SBK is 45,000. Mother said, नहीं, मेरी बेटी के तो जो बेस्ट है कर दो, बस उसको तकलीफ ही नहीं होनी चाहिए, दर्द नहीं होना चाहिए, money is not a problem. And they got the most expensive procedure done for the daughter. The daughter did very well. Then the mother also had a power. She said, मैं भी करा लूँ, मैं ठीक है आप भी करा लो Contura 1 lakh rupees. मेरी इतनी उम्र हो गई डॉक्टर साहब, मैं अब इतना खर्चा करके क्या करूँगी, मेरा तो अब वही 40-45 वाला कर दो, उससे दिखाई तो देगा ना ठीक, हाँ दिखेगा, ठीक दिखाई देगा, हाँ मेरा तो फिर वही 40 वाला कर दो, मेरे को क्या ज़रूरत है, फाइन कर दिया. Her father had a cataract. So I told them about these lenses 45-50,000. सब कुछ सुन लिया. ओ जी जो आपका पैनल में आता ना वही कर दो बस, हमने अपनी जेब से कुछ नहीं खर्चना, आपने जो करना है पैनल से कर दो. अब बुढ़े हो गए जी, अब क्या कराना, अब क्या इन सब शौक में, राइट. सेम फैमिली, वेरी वेल टू डू फैमिली. दिस इज द अप्रोच ऑफ अ टिपिकल इंडियन फैमिली, है ना. So when it comes to the children, people are ready to spend any amount, a little restricted on their own self. And on the old man, they don't want to spend anything. उससे ज़िंदगी देख ली ना, अब क्या पैसा खर्च करना है इसके ऊपर. For children, they are very fussy. So money is never an issue when you are doing a refractive procedure. Money is never an issue. उसके बाद जेब में पैसा नहीं होगा, लेकिन बच्चे के लिए तो वो खर्च ही देगा, कैसे भी कर देगा. You can use any. It's not a big deal. You use a normal HPMC 2%, 1%, or you use a cohesive like a Helon or something, or you don't use any viscoelastic like I do. All of them work pretty well. But yes, when you start, you should use a viscoelastic, preferably an HPMC. When the doctor is doing a procedure, he is conscious about the costs. Naturally, he has to make some money somewhere, no? At the end of the day, he also has to make some money. So he cannot save in the cost of the lens unless he uses an Indian lens, which the patient may not let him use because that brand value. But he would save on probably not a viscoelastic like Viscoat or Helon GV or something. He can use a simple HPMC. It makes actually no difference.
So is there any age restriction for myopia child to do ICL? Not less than 18.
Okay, so we say all refractive 18 and above when the number becomes stable. That's the golden rule. However, there's another add-on to this story. I had a child, 8 years old, 9 years, one side emetropic, other side he had a high number, -10, and was amblyopic, and he has done all his amount of patching all these years. Parents after the child, आँख बंद करो, ये करो, वो करो, करते करते उसकी vision develop नहीं हुई खास. And they said, what can we do? At that time I said, you finish your quota of patching wherever. If it doesn't work, we'll put in a lens in your eye. He had some, I think, about 7-8 spherical and about 4-5 cylinder. At the age of 10, they finally agreed under GA to have an ICL in the eye with a cylinder. Just correcting the cylinder improved their vision by 2-3 lines. The child came from 660 to 660 or 636 to 612. And then we said, okay, you could try patching or you could try one of these softwares which are coming up now to handle the rest of the treatment. And probably they improved by another 1 line. They didn't come 6.6, but otherwise the child would have been doomed to 6.36. And now he's at least emetropic, both eyes. His face is not ugly. He doesn't wear a 10 spectacle there and 1 here and this and whatever. So that is a very fair indication for doing something at a young age. उसके बाद अगर नंबर आधा 1-1.5 बढ़ भी गया तो क्या फ़र्क पड़ता है यार, उसकी बच्चे की ज़िंदगी तो बच गई. And it's reversible. Yeah. Come again.
Post-cataract surgery refractive surprises. Do you use ICL?
You mean the piggyback version? As a piggyback?
Is same ICL?
Yeah, as a piggyback ICL on an IOL. Yes, we did a couple of them, and they worked very well. All ICLs work very well as a piggyback lens, except for one thing. You have cheaper alternatives. You have the Sulcoflex, which costs about 10,000, 10,000, 12,000. And you have the IPCL add-on lens, the Care Group. And that also works extremely well. And the advantage of it is they can do any amount of cylinder. I just did a child, about a teenager now, very high cylinder, after a basic cataract surgery in childhood, I think 6, 7, 8 cylinder. They made that add-on lens for me with that 8 cylinder. It was a plus-minus combination, which was a very difficult combination. The child became emetropic. I think 0.25 spherical was the residual. Fantastic.
So they have different calculations for that?
Yeah, and they do all the calculations. Okay. So I think we'll stop this part here, and we'll ask Dr. Sarika to take away your fears on a very important issue, which is cataract and glaucoma.
Sorry, one more question. How can we avoid glaucoma? Because I have faced 2-3 cases.
Dr. Sarika will tell you.
Sir, whom do we offer presbyopic lenses?
Huh?
Whom should we offer presbyopic lenses?
Those people who are at 45 loaded with money.
Last time. This one.
No, but the presbyopic version again changes with age.
So क्या हो? तो आपने उसको अगर डेट करेक्ट कर दिया तो उसका आधा पौने तो चेंज होगा.
Connect with this.
They're all
Then,
increased
Because
depth of
I
focus.
must say that they won't spend on this.
Yeah.
To correct when they're 1.5.
madam, how long are you going to change the lenses?
No, you won't know.
You won't.
He will have depth of focus lens and add 1.5. So he's pretty comfortable. So सब कुछ
मेरा
दिखा इसको
CPS.
बहुत बारीक पढ़ना हो गया. When he gets 16 तो थोड़ा सा चश्मा लगा लेगा.
अच्छा, कर लो.
अपार पढ़ने के लिए. But he's very happy. And that would happen several years later, so he won't blame you. ऐसे जब मैंने किया था तो ठीक था, तो age से थोड़ा बहुत change आ गया. So with age there will change. So that's a non-dominant eye. Put it in both the eyes.
If there are no contraindications, which one would you prefer, a LASIK or a phakic IOL?
I'll give you an example. This is a very interesting example. Which one would you prefer, ICL or a LASIK, right? If it is a patient, a normal patient, you would say standard 1 to 8 LASIK over 8 ICL. It's written there, yeah. If it is somebody very close, very dear, let us say your daughter, who has a number of -4, you will spend 3 years trying to think and you'll talk to everybody, sir, मैं क्या कराऊँ इसका? ICL कराऊँ कि LASIK कराऊँ? वो कहता है LASIK, वो कहता है ICL, वो कहता है PRK, वो कहता है trans PRK, huh? You need a connector? Here, this one, sorry. वो कहता है trans epithelial PRK, which is that all those streamlight and all those things, you know. And the debate will, everything will have some negative. You say, normal flap, और या कोई चोट लगी, flap हिल गया तो, without a flap, trans epithelial PRK, हेज हो गई तो, ICL,
Glasses. That's why most ophthalmologists continue to wear glasses.
no, that's not true. That is not true. I have done quite a few procedures on ophthalmologists, both ICL and contours, and on their children, their daughters and children, which is even a bigger challenge.
No, they must not be doing LASIK procedure. If they are doing LASIK procedure, they will never get it.
You are true to 90% of the extent. True. Yeah.
I got right eye LASIK done, left eye -2, no LASIK done. Without any sutura, I am good.
50%
And 10 years back I got it done.
Dr. Chaudhary, I need to.
Okay. So wait. Ek minute. Let us give Dr. Sarika a time. She's prepared a wonderful presentation. Really good. It
I
is.
don't think I'll get a chance
It is.
to
It is
speak
really
with Dr. Chaudhary.
mind blowing. A real thought process presentation. So let's give her a chance.
So good afternoon to all of you. So, one sec, please. ये double कैसे आ रहा है? Okay, fine. So most of us, when we plan the ICL surgery, there are two things we are afraid of. One is cataract and another is glaucoma. So we'll discuss each of these. First, coming to cataract after ICL surgery. So there are two main reasons for cataract formation after ICL surgery, which we have learned from our experience of last 15 years. First is ICL crystalline lens touch, and the other is excessive irrigation or irrigation fluid jet hitting the anterior capsule. So first we'll discuss about the one which most of us are aware of and afraid of, that is ICL and crystalline lens touch. So this is how a normal vault, ICL vault in the eye should be. The vault is a space between the back of the ICL and the anterior capsule of the lens. Normally it is 500 microns plus minus 250 microns. Here it is almost 500 microns. It is measured by comparing it with the corneal thickness, which is approximately 500 microns. We need a good ICL vault so that it allows for the movement of the aqueous humor. If the vault is very less, it causes aqueous stasis, which can lead to the formation of cataract. So this is a case we did around 15 years ago of minus 30 diopters. We did bioptics for him and we implanted an ICL for him. That was old V4 model, that is ICL without holes. So this is how his vault was. The vault was very shallow and there was an ICL crystalline lens touch. So at that time, we didn't have much experience and we thought whether we should exchange the ICL for a higher size or shall we continue with the same and observe the patient. So we decided that we will continue, we will not exchange the ICL and we'll just wait and watch. For years, it worked very well. The patient was following up with us on yearly basis until in the 5th year, he developed a small speck in the periphery. So again, it got us thinking, shall we exchange it or shall we just observe? So since the cataract was peripheral and it was not affecting the vision and it was very small, we again waited and followed up the patient. So it worked very well for 10 years until in the 10th year, the patient developed a central cataract and we did the ICL surgery. So through this case, the message I want to give is that with the ICL crystalline lens touch and that too with the old V4 model, it worked so well for 10 years. We didn't need the cataract surgery for 10 years. So coming to another similar case, this is another case of cataract with old V4 model without holes. There is a speck again in the periphery as seen in diffuse illumination and slit lamp illumination. This also occurred after 5 years of ICL implantation. So all these cataracts occurred with old V4 models only. Since 2014, since the time we have started using V4C model, that ICL with holes, we have not encountered a single case of cataract, even with such low vaults as this. Here the vault is less than 100, and still we are following up the patient and there is no evidence of cataract. So this is how we counsel a patient who comes and asks us about the risk of cataract after ICL. We tell them that the cataract used to happen in early V4 models. It doesn't happen anymore with the newer V4C models, that is ICL with hole. There are several studies on zero incidence of cataract in last 5 years. The incidence of cataract is as low as 0.1%. And we tell them it is always safer than going out on the road. So if the advantage of implanting ICL is huge and the risk of cataract is minuscule, then this risk is worth taking. And even if in the rare situations cataract does happen, it can be managed 100% with the cataract surgery. There is never any loss of sight. So now coming to the next reason, which most of us are not aware of, is excessive irrigation or fluid jet hitting the anterior capsule. Not much have been reported about this in the literature also. So these are the pictures of first post-operative day after ICL insertion. We saw the white deposits on the anterior capsule of the lens. It appeared like a membrane on the diffuse illumination, and this is how it appeared on the retroillumination. These deposits decreased on the follow-up, and by 3 months they were almost not there and the vision was not affected. We thought that these white deposits were the retained viscoelastic material, which cleared on its own with time. We saw 3 to 4 such cases in a short duration, and we thought that if retained viscoelastic is the problem, then why not stop using visco and start using hydroirrigation for ICL implantation? So we started hydroimplantations. So after starting hydroimplantations, almost 3 months later, we saw another case of such white deposits on the anterior capsule. We were using the viscoelastic of a very small amount in the injector only to load the ICL. And we thought how such minuscule amount of visco can deposit on the ICL and can be retained. So we thought about it, but we didn't get any answers until after 1 year we got another case with huge amount of deposits on the anterior capsule of the lens. This time we checked up the literature and we came across a case report which talked about vacuolar changes on the anterior subcapsular space of the crystalline lens, which developed after the irrigating procedure through the narrow space between the ICL and the crystalline lens. So these white deposits were actually the vacuolar changes that happened on the anterior capsule of the lens, and this was not the retained viscoelastic material. And on OCT, ASOCT, these vacuolar changes appeared like bleb-like lesions, and these were transient. They gradually improved with time. So we also started doing ASOCT for all our patients, and I'm showing you a case which was very severe. Here you see the vacuolar changes on the anterior capsule of the lens, and this membrane here, these vacuolar changes organized here to form the membrane. So this was the most severe case we saw. So what we conclude from this is that visco has no role in inducing subcapsular vacuolar changes or cataract. The excessive irrigation can cause transient anterior subcapsular vacuolar changes on day 1, which improves with time. And the most important message which we learned from this is that during hydroinsertion or visco removal, do not irrigate under the narrow space between the ICL and the crystalline lens. Because when we go beneath the ICL, the space is very narrow, and it hits the anterior capsule and bring about these vacuolar changes. And even if you do the irrigation flow and irrigation time should be very minimal. We can, if we have Centurion or other machine, we can try the low IOP settings, or we can keep the bottle height low so that the irrigation flow is lower. So coming to the next concern, that is glaucoma after ICL. So there are 3 main reasons for rise in IOP after ICL insertion. First is residual visco, the second is high vault of the ICL, and third is ICL placed upside down. Coming to the first one, the residual visco, if there is a retained visco, it clogs up the trabecular meshwork channels and causes the immediate rise in the post-op period, which needs anti-glaucoma agents for a couple of weeks until the visco gets washed away. Now the next and a very important cause for glaucoma is high vault of the ICL. Generally we say that the vault is high if it is more than 1000 microns. So what do? If the vault is high, we follow up the patient with the IOP monitoring and we check the angles on gonioscopy and ASOCT. If the IOP is normal and the angles are open on gonioscopy and OCT, we wait and watch. But if the IOP is raised or angles are closed on gonioscopy and ASOCT, we exchange it to the one size smaller. I'll discuss both the scenarios. So this is a case of high vault. The vault is almost 1400 microns, but ASOCT shows that the angles are open, and the IOP for this patient was also normal. So we are waiting and watching, and we have followed up the patient for 6 months. There seems to be no problem. And there should be no hurry in exchanging the IOL, because the normal vault of the ICL also decreases with time. Generally, the vault decreases by 30 to 40 microns per year. Okay, but in this was a very unusual case. In Feb 2021, the vault was 1583 microns. After 1 month, the vault fell by 100 microns to 1484. After 8 months of follow-up, it decreased by almost 170 microns to 1316. And last month in April 2022, the vault was 1200 microns, that is less by 370 microns from its original vault. Though it's an unusual case and we still don't know the cause. But we shouldn't hurry up in exchanging the ICL if the IOP is normal. Now, so when do we exchange the ICL? When we have very high vaults and the IOP is high, we exchange it. So far, we have done 3 cases of ICL exchange because of higher vaults. So here is one such case. Here, on ASOCT picture, you can see that the iris is almost touching the cornea in both the eyes, and the angles are closed. And the vault was so high that we saw ectropion UVA. The ICL was pushing the pigment epithelium from behind. So we put the patient on the anti-glaucoma agent, and we decided to exchange the ICL with the smaller size. So you can see the AC is very shallow, and there is hardly any space for even side port entries. We used up the same side ports and the main port because the surgery was done immediately within a week. This is so shallow that the side port is hitting the iris. Normally exchanging ICL is not that difficult, but with such high vault, we had quite a struggle in taking this out. Now we generally, normally we take out one of the haptics out in the anterior chamber and then we pull out from the eye. But here we were struggling to bring out one of the haptics, but we were unable to do so. So we somehow managed to grab one edge of the ICL here and we pulled it out directly from the eye. And exchange it with the smaller size. So this is how the vault was after the exchange. The angles were open. So last but not the least, this is the case of ICL placed upside down. We didn't have any of our cases. This was presented by Dr. Sanjay also. This case was done elsewhere and the patient presented to us after 4 years. So when we saw the patient, the IOP was high, the AC was shallow, and there were a lot of anterior synechiae. The CD ratio was 0.7, and we decided to bring out the ICL and exchange it with the smaller size. We even tried to break the synechiae, but it was so strong that we couldn't break all the synechiaes. So now we are following up the patient. The vault is normal, the IOP is also normal, but the patient is still on anti-glaucoma agent. Thank you.
And there was no cataract in this eye.
Yeah, and there was no cataract in the eye.
Oh yes, anything. All these strong viscose or Helon, GVN, they would be the best thing because everything is so tight inside, the iris is all stuck, all 360 degrees. You really need a very open chamber to work in the AC.
For 4 years, it was upside down, no causing any cataract, even no glaucoma in the 30 times.
No, glaucoma was there.
Later on, sir,
Yeah.
after 4 years, it developed.
No, I don't know when it developed, but the patient was on glaucoma treatment for a long time.
And the
But
reflective reflection was corrected. Reflective error was corrected even with upside down.
No, there was a little variation. It was corrected, but there was a little variation, yes.
Flip the ICL when it's upside down inside the chamber.
Can you flip it down?
We could, but this was without the hole. So we took it out and replaced it with the one with the hole.
If you see it the next day, if it's an ICL which is available now with the hole, you can flip it inside.
Yeah, you can flip it inside, yeah.
While doing the surgery,
ये connected कहाँ?
sit down. Can you do it inside the chamber?
No, you should bring it out. Turn it around and then put it in. Otherwise, you will rub against the whole endothelium and you'll also rub against the lens. You will injure both the tissues.
There was a high vault. So at time of surgery, you were not able to find us, or it was done somewhere else. At the time of
No, that high vault was ours only.
so what the time of surgery,
it was obvious, but now that we have put the lens in and it was in position, we thought let us see what happens. How do you tell the patient that bhai maine lens nahi dal paya? Very difficult situation, na? Yeah, sulcus, what we do is white to white. White to white has no relation whatsoever with sulcus to sulcus. So you can have any variation. It's a different tissue.
So no need to measure sulcus to sulcus. We can't measure, but how to?
With only with UBM, no?
No, it is important in the ICL implantation or only white to white?
White to white is the simplest way to put an ICL. If you have the other measurements, it's even better. A sulcus to sulcus is naturally ideal, but then it depends on how you acquire the data. And again, in the acquiring process, there can be a lot of variation.
What would be the reason of decreasing what with the passing of the years when the lens size is increasing?
So lens size has got nothing to do with the position of the ICL. ICL is in the sulcus. ठीक है ना? So ICL is not going to go up, na?
What is it between the ICL and lens?
The vault is between the ICL and the lens. Right. The lens will grow with age, right, and the vault will decrease. It is not necessary that the ICL is coming down. But that growth of the lens is normally 20 microns a year. But this happened, how much? 300, 400 microns difference in 1 year? I still don't know why it happened. It was just a matter of chance that we are doing ASOCTs every visit, and one of our doctors said कि sir ये देखो ये तो vault खुद ही कम होते जा रहा है, and we really didn't have an answer. It depends how the sulcus there is, because again I said normally we say the white to white is maximum horizontally, less vertically. ये तो है ना, the cornea is not round ना, it is stretched like this. So it should also follow कि the sulcus should also be stretched more like this and less vertically. But then the wall should increase if you take it vertically. But many places it has been documented कि take it vertically and the wall decreases, which further goes to prove that the vault to vault has no relation to sulcus to sulcus. It has no relation to sulcus to sulcus. No? Angle to angle still has a relation to sulcus because both are uveal tissues. But white to white has absolutely no relation. It's just that it works in 99% of the cases.
OCT, how frequent we have to do post-op to measure the vault whether we are?
Only if there's a tricky situation. If everything is fine, the patient has come and we just see everything is fine, go back यार. जितने इन्वेस्टिगेट करोगे उतना सस्पिशियस होगा कि पता नहीं क्या हो गया मुझे. क्या डॉक्टर साहब सब कुछ ठीक तो है ना? With the best of result, you are putting suspicion in his mind. हाँ सब कुछ दिख जाता है, वैसे दिख जाता है. Vault is almost the size of the thickness of the cornea. Cornea thickness is 500 microns. The vault should be 500 microns. So the slit, the size, thickness of the cornea should be the amount of vault, plus minus 250 microns.
What is the most common complications that you see after ICL?
Hmm?
What is the most common complications you face after ICL?
Nothing really. That's why it's safe. There's actually nothing.
With 1000 volt, if the patient is comfortable, no issues, can we just observe?
I showed you 1500 volt and we didn't do anything. 1500 is unimaginable. Anything over 1000 we say is very high. Now people are saying that 1000 is the real vault. You should target at 1000. Why? Because the lens is going to increase in size 20 microns every year. In 5 years it has increased by 100 microns. It's got 100 microns closer to the ICL. In 20 years it has got closer by 400 microns. And then one day, once everything will start touching the ICL. पता नहीं अब कैरेक्टर कब आता है उसका?
I just wanted to ask, which is the oldest patient who has received ICL, in your experience?
18 years. But the oldest ICL done.
Oldest, matlab the patient's age. What is the
Age
highest
oldest?
age? Yeah, 40 years, 50 years, 60 years. Like at what age? What is the oldest patient who received an ICL? And secondly, are there any?
A general concept is that if at all you may, a person, if he has to have cataract at 70, he may get it at 60. Because ICL is still a 19-year-old technology. So if you put an ICL at the age of 25, so that guy is still about 45. So where does that data come in from?
And oldest patient who received ICL?
I think something about 60.
60 years with a clear lens?
Star people give a cutoff at 45 years.
Okay.
So they say.
Sir, can you tell us the exact name of the instruments which you use? The two instruments which you use?
So, okay. So the two instruments, one is that alligator forceps, and now some of that is the original star model which has been going on for 15 years. But it's a little big, and many times when you try to catch it, it keeps pushing the lens behind. So we have designed another new model, which is with epsilon, which is a little shorter and a little wider, because a big grip is good grip is important, and you should just go and catch. Not that you're holding it and it slips further, hold it, it pushes back further. So that is available now. Probably in this exhibition, they may not be displaying it because we just finalized the design about a month back. But you've been using it for almost 6 months now, testing it. You talk to them that we want Dr. Chaudhary's design and they'll give it to you. And then there is this manipulator. That also was a thicker manipulator. We have just cut it down to make it a little thin so that it's easier to manipulate within the eye. So that's just a regular manipulator. My ICLs, something over 5,000, I guess. Again, you will get it by the person who provides you with the ICL.
Sir, in cases of lens exchange, who bears the cost of second lens?
If it is genuine, you have the pictures, you give it to the company and they'll do it. They have that much of a margin, star people, the dealer.
The explantation forceps is the regular IOL explantation forceps, or how do you pull it out?
No, I use what is called a IOL cutting forceps and scissors. They have a better grip. So I use a one which is from Indo-German. That of all the forceps I have experimented, that has the best grip. Crocodile is the one which I showed you here, na? That also works, but its grip is not so good. But let me thank everybody. Thank you for such a patient listening. It was a pin drop silence, so it was very encouraging. Everybody was tuned in. Thank you so much.
Any case where you
Yeah.
came to VA post cases?
Sorry?
Not with these newer models.
No, that's obsolete now. Obsolete.
We would rather exchange. PI won't help anyways. They are already the holes. So PI won't make any difference.